So what is the hypothalamus? The hypothalamus is a diencephalic structure, and it's a diencephalic structure which is made of gray matter. It's a gray matter sheet. Now, the gray matter sheet is in such a way that it's a bit, if you can imagine it, you can visualize it as forming a V, right? And this V makes it in such a way that it forms the lateral and the inferior borders of the third ventricle. So it forms the lateral and inferior borders of the third ventricle. And as you probably guessed, hypothalamus, because it's below the thalamus. So you have two thalami, and these two thalami are situated above the hypothalamus, and they equally form the lateral portions of the lateral borders of the third ventricle. So the inferior lateral portions of the third ventricle are formed by the hypothalamus, whereas the superior lateral borders of the third ventricle are formed by the thalami, by both thalami. So the hypothalamus is a really small structure. To better understand it, we'll have to do things a bit out of proportion, really see them really big, to get an idea of what it is. It is so small, it weighs only 4 grams. However, it's able to give directions, control, communication to all organs in the body through the endocrine system, for example, through the nervous system as well. So it's a very important structure in neurosurgery, especially. Which are the landmarks we can describe to the hypothalamus so we can all situate ourselves? Like we said, the hypothalamus is a diencephalic structure. So as a diencephalic structure, it is in intimate relationship with, on one side, the like at the back of it, you have the midbrain or mesencephalon. In front of it, you have the optic chiasm. While lateral, like we said, medial to the hypothalamus, you have the third ventricle, and then lateral, it's contiguous. If that's the word I was looking for. So lateral to the hypothalamus is contiguous with structures like the deep gray matter nuclei, as well as elements of the internal capsule. You equally have the thalami, like I said, above the hypothalamus, both thalami above. The thalamus below will continue as the tuber cinereum, and then the infundibulum, then go on to be the pituitary gland. Very important again because of the close relationship between the hypothalamus and the pituitary gland. So what we just said here, this is a sagittal cut of our brain. So here we have the cerebrum. Here we have the white matter substance. Here exactly the corpus callosum, the septum pellucidum. We have the body of the fornix here. This is the interthalamic substance which connects both thalami, so that both thalami can be able to communicate. So in front, like we said, we have the optic chiasm. So the optic chiasm sort of gives us an anterior boundary to the hypothalamus. And we said if we go backwards and below, we find the mammillary body. This gives us another boundary. And we equally said that the hypothalamus was in front and seated above the mesencephalon. So in front here, what we have is the interpeduncular fossa, a very important anatomical landmark as well. So the zone of interest is this zone here, which is formed of this gray matter substance, sheet-like substance, which is sort of like a V. There's only one hypothalamus, but because it's like it has that V form, you can find one of the sheets on the left side and one of the sheets on the right side. So this is the area of interest here. Now, if we look at a view of the inferior surface of the brain, obviously we can see our cranial nerves here. And obviously we see cranial nerve 2 meeting at the chiasm. So this is the anterior surface here. We have a tuber cinereum, which goes on to be in relationship with the infundibulum, then the hypophysis. So we have our mammillary bodies here from both sides. And obviously here we have the mesencephalic structure, and that's the midbrain. So here we have a cut, which is coronal. So what we have here is the third ventricle, and these black structures here are optic tract at the level of the chiasm here, that midline. Now, around the third ventricle, like we described, if we look lateral and inferior, we have the hypothalamus. So the hypothalamus will be subdivided into nuclei. This is a division which is partly anatomical, partly functional, and there's been a lot of advance in terms of neurobiology, which has come up with other forms of classifications and divisions. So this is a simplified classification just to get an idea of the hypothalamus. But if you want to go deeper, then you have other forms of classification based on the neurons that compose the different nuclei and their functions as well. So in this sagittal view, what we have to be situated, we have here structure called, that's the midbrain, below is the pons, obviously. We have a white matter substance here, corpus callosum. We have a septum pellucidum, the interthalamic substance here. This is the pituitary gland. This is the optical chiasm here. So from this area to here, we have our hypothalamus. Now, like I said, this is out of proportion because when you see this and then you see the midbrain, obviously you understand that this has been sort of we've blown it up just to see all these different aspects of the hypothalamus and its relationship with the different structures. So like we said earlier, the hypothalamus has multiple nuclei. These nuclei are subdivided. A quick subdivision would be to have medial nuclei and lateral nuclei. And this division is done by part of the fornix, which gives it a division which is not really sagittal, it's parasagittal. And so we're going to be talking about medial nuclei on one part and then lateral nuclei on the other. However, you'll notice that there's nuclei that are shared between the medial and lateral. And equally, there's we're going to talk about a very specific nucleus, which is not really anatomically part of the hypothalamus, but it's considered functionally to be part of the hypothalamus. Once again, these divisions, like I said, it's just a simplified division, just to get an idea of what hypothalamus is like. So we start with the medial nuclei. So the medial nuclei will go on to have 3 other subdivisions anatomically to get an idea. And these subdivisions follow from optical, supraoptical nuclei. Then we're going to talk about the tuberal nuclei, as well as later on, we're going to talk about the mammillary nuclei. So that's for the medial, and then for the lateral, we don't have a specific division. Now, one way for the medical students to understand some of the names here, some of the names are anatomical in terms of structures, the structures to which the nuclei are related or where they are located. But then you have some of them which are based on orientation. So one of the things that's challenging for medical students is the concepts of ventral, medial, lateral in terms of the central nervous system. And this is why we started with embryology. So if you remember, when we spoke about the embryology of let me get a pen. So when we spoke about the embryology of the central nervous system, we said we had first of all we had like 3 sheets: ectoderm, mesoderm, endoderm. Then we said this sheet here, this one, went like this, And this here was called neural crest. And then these two met up and gave a tube, right? And at the center of this tube, later on, this is where CSF will be. Now, all of these cuts have been made in such a way that they like, we're going to say coronal cuts. Now, if we look at the whole tube in itself, when it gets the three vesicles this way, right? This way, this way. Okay, so this here is cranial, and this here is caudal. Yeah. So later on, this portion of the prosencephalon is going to do a flexion. Very important to understand. It's going to flex like so, like this way, which means the cranial portion finds itself here. And what we get being called cranial can equally be called rostral. We can equally talk about rostral. But what's the problem? What's the change that we have here? So now this portion was initially ventral, and this portion was initially dorsal. This was ventral, this was dorsal. And now that we've had this flexion, ventral finds itself inferior and dorsal finds itself superior. This is only for the prosencephalon, because if you're talking about the mesencephalon and the rest of the structures here, that's the pons and the medulla oblongata, this stays ventral, this stays dorsal. But when you're here, ventral is inferior, dorsal is superior. When you're here, ventral is anterior, dorsal is posterior. Very important. And if you keep that in mind, it's easy to understand the different the different nuclei, nomenclature of the nuclei in the hypothalamus. So what we have here is the division, which is parasagittal. This is the division. Everything that's light blue here is lateral. Everything that's in this white area is medial. And we said we're going to divide it into 3 areas. What you see green is supraoptic. The pinkish red is tuberal, and mammillary. It makes sense because we said below our hypothalamus, we have this projection called the tuber cinerum, which is in relation with the infundibulum, which later on continues as the pituitary gland. And at the back, we have these 2 organs, which are called the mammillary bodies on both sides. So obviously, all the nuclei here are mammillary, these ones are tuberal, and these ones here are supraoptic. Supraoptic because it as an anterior border of the hypothalamus, we describe the optic chiasm. So all of this makes sense, I hope. Now, talking about the names, we equally said that the hypothalamus is one. However, it's sort of V-shaped. So this is only one side. This is the right side. So what you want to have in mind is this and then something here, in such a way that there's an empty space here. And this empty space is the 3rd ventricle. Now, if this is the 3rd ventricle, it's only logical that what is next to the ventricle is periventricular, right? So these are the periventricular nuclei, and this will be the paraventricular nuclei. And because in the anterior location, we had an optic chiasm, this will be the suprachiasmatic nuclei because it's above the optic chiasm. And after the chiasm, we have optic tract, and we have the supraoptic nucleus. This here is anterior. Now, this is ventromedial. This here, ventromedial. Once again, remember, we've got a flexure. So this is ventral. This is dorsal. I'm sure you see it more better on like other cuts. Mammillothalamic, because the thalamus is above here on both sides. So if I was going to overlay the thalamus, I'll do this. And this here is the pulvinar, of course. This is a medial lateral on both sides, obviously. So mammillary gland, mammillothalamic. Here, tuberomammillary, mammillary, lateral mammillary, medial mammillary, and obviously the posterior. So posterior, anterior. Then you've got the lateral mammillary, the medial mammillary, tuberomammillary. So let's keep going. The lateral nuclei. Here we have a preoptic nucleus, part of it, because we said the preoptic nucleus, which is not really anatomically in the hypothalamus, but functionally it's part of the hypothalamus. So this preoptic nucleus, part of it is medial, part of it is lateral. Part of the suprachiasmatic nucleus as well, medial and lateral. The supraoptic nucleus, the lateral nucleus, tuberomammillary. Now, the difference I've been making for a while about having ventral structures and was ventral and then dorsal, yes. So the ventral structures, as you know, ventral medial, as you notice, ventral medial nucleus as it is here. You see it below. When you're talking about the dorsal medial nucleus, you see it's above. Ventral medial, because here is the ventral, this place is dorsal, and medial because obviously it's close to the midline. So this is it. And this is a third ventricle. And obviously lateral to the third ventricle, if you have a nucleus, you call it the paraventricular nuclei. And above these structures, what you have, the thalamus, right? Above the hypothalamus, you've got the thalamus. There they are. And obviously the interthalamic substance will be going through there. And obviously they are in relationship with the midbrain, so the mesencephalon. And we said the fornix was that structure that gave us that division between the medial nuclei and the lateral nuclei. So once again, here we have a cut with the stain. This empty space is the third ventricle. So logically, this here will be the periventricular nuclei. So you have the paraventricular nuclei here, the dorsal medial nucleus. Once again, look at it here, dorsal medial nucleus, ventral medial nucleus, arcuate nucleus. This here black is optic tract. If it meets, it becomes the optic chiasm. Makes sense. So lateral nuclei are here, medial nuclei are here, and between the medial and lateral, we have a few that are shared. That's the preoptic and the suprachiasmatic nuclei. We've already seen this, but I come back with it again. So to make sure everyone understands, always remember medial, lateral. Medial first division is supraoptic, tuberal, mammillary. Okay, so talking about a few of those nuclei and some specific functions. So the suprachiasmatic nucleus, which is basically part of the medial and lateral, regulates hormone secretion. This is going to be very important because of the nictomeral secretion of hormones. Important because take cortisol, for example. The secretion of cortisol during a 24-hour period is not the same. So early in the morning, you get high concentrations of cortisol. Late at night, you get low concentration of cortisol. And this is actually related to the fact that you get events like asthma, pregnancies, mostly at night. However, if you're talking about heart attack, for example, if you're talking about heart attack, it's when you get the most stress, right? So when you get the stress hormone most secreted, you're going to have more events of heart attacks. And this is related to this diurnal secretion. The ventral medial nucleus regulates feeding behavior, and it's actually related to rage. So it explains why some of us are very angry, very annoyed when we are hungry or when we've not eaten enough. The dorsal medial nucleus controls this rage behavior, like we said. So, and lack of satiety will lead to aggression. The mammillary nucleus contributes to the limbic system, and it's part of what we call the Papez circuit. The Papez circuit is the medial limbic circuit, and this is in relationship with emotional expression. So limbic, when you see the limbic system, you have part of the cortex, frontal cortex, you've got the amygdala that participates. You've got the hypothalamus in that's the mammillary nuclei here, and they're part of this Papez circuit. So here we have a cut. I hope everyone is already familiar with this. So you always situate your third ventricle. So here we have a posterior nuclei, and everything that's here is considered periventricular. The optic tract, mammillary nucleus, and the fasciculi. We'll be talking about these different fasciculi because there are connections between the hypothalamus and other structures in the brain. So these connections, we can divide them into principally afferent, efferent, but there are equally other connections in the sense that you have connections between the hypothalamus and the pituitary gland. So we're going to talk about them in this classification. So afferent, they're leaving from some other organ and coming all the way to the hypothalamus or one of its nuclei. So most of these fibers already tell you a lot about the origin in terms of afferents. So if you know it's going to hypothalamic nucleus, when you're told it's coming from the medial or spinal lemnisci reticular formation, you already envisage that it's going to be visceral and somatic. Visual, obviously, from the retina. Medial forebrain, obviously, olfactory, auditory, inner ear. Cortical, hypothalamic, frontal lobe, obviously. Hippocampal, hypothalamic, you have the answer. Amygdalo-hypothalamic, again, same thing. Thalamo-hypothalamic, tegmental from the midbrain. And in terms of efferents, from the hypothalamus or one of its nuclei all the way to another organ. So you have descending fibers, which will go all the way to the parasympathetic and sympathetic areas of the spinal cord. So as a reminder, parasympathetic is cervical and sacral, and when we talk about sympathetic, is principally thoracic, thoracolumbar region. So mammillothalamic goes all the way to the cingulate gyrus. Mammillategmental goes all the way to the midbrain, and we've got other pathways that go all the way to the limbic system. We spoke about this limbic system elements. So we've given a brief overview of these elements, and when we'll be talking about the function of the hypothalamus, we'll better understand why or how these connections exist. So on this sagittal cut of the brain, we all recognize here we have a cortex. This is the frontal cortex. Frontal cortex is shown here because of the connection we have at the level of the limbic system. Like we said, we have elements of the frontal cortex. We've got elements equally of the white matter substance here, like the corpus callosum, and we've got the hypothalamus via the mammillary bodies. So this is a more symmetrical the diagram of the hypothalamus. So this is on one side, this is on the other side, but they're not separate. They're joined at the level of at the inferior level, and so they're bordering a space, and this space once again is the third ventricle. And above this hypothalamus, because the view we have is superior, so above here, what we can put over here is the two thalami. Sorry, that was not very symmetrical. The two thalami here in terms of structure. And in front, what we expect to have is this, right? The optic chiasm. This is what we expect to have here. Now, if we're looking below this structure, somewhere down here, we're going to have the tuber cinereum. And below and behind, we're going to have the mammillary bodies. That's below this. Very important to understand these structures. Obviously, here we have part of the limbic system. So you've got part of the hippocampus and the amygdala. all on both sides. And we can see the different connections we're talking about. We spoke about afferent connections and efferent connections. We saw that there were connections from the hypothalamus to the cortex, to the spinal cord, to the limbic system, equally going to the cingulate gyrus. So quite a few of them. Now, a very, very particular and special connection between the hypothalamus and the pituitary gland, or hypophysis cerebri. And here in a diagram, what do we have? Well, this is our anterior pituitary gland and a posterior pituitary gland, and then this is our stalk, right? And we have a tuber cinereum, and then we have the rest of the hypothalamus here. So what is interesting here is to describe the relationship between the hypothalamus and the anterior pituitary gland, and the relationship between the hypothalamus and the posterior pituitary gland. So we all know this. The hypothalamus produces two peptide hormones, and then those hormones get stored at the level of the posterior pituitary. That's to say the antidiuretic hormone and oxytocin. We're going to speak later on about the special functions, but these hormones are equally neurotransmitters, because the posterior hypophysis is actually neurohypophysis, whereas the anterior hypophysis is an adenohypophysis, which is that's to say it's glandular. And between these two, there is a very particular circulation, blood circulation, which is a portal circulation. So the circulation here, we'll speak about the vascularization in terms of nutrition, but in terms of function, it is important for the hypothalamus to be able to detect changes in the blood. To detect changes in the blood, given that it's a CNS structure, you know CNS structures are not in direct contact with blood normally. However, there's areas of the brain where you have to have direct contact with the blood. It's the case with areas that can elicit vomiting, like the area postrema and the hypothalamus as well. So the hypothalamus cannot get a phony version of the blood, if you can say, a diluted version. It has to be in direct contact to say, okay, this is what is up with the blood. For example, in terms of osmolarity, if the osmolarity is up or down, so that you can decide what to do with ADH, for example. So it has to be in direct contact with that. But then it equally has to be able to communicate directly with the hypophysis, which is the role of this portal system here. In terms of vascularization, the hypothalamus, because it's very important, you expect it will be richly vascularized, and it's vascularized from so many branches. You've got branches from the anterior cerebral artery, and like you know, anterior cerebral artery is from the anterior circulation at the level of the circle of Willis. So this is actually from the internal carotid artery. It's got branches from the posterior cerebral artery, which is from the vertebral basilar circulation, and from the posterior communicating, which is between the posterior cerebral artery and the middle cerebral artery. So permitting communication between the posterior circulation and the anterior circulation. In terms of the venous drainage, it drains through the intercavernous sinuses. So here, this is venous sinus, like you all know, and multiple venous sinuses at the level of the brain. And the closest here is the intercavernous sinus, which is, the cavernous sinuses are directly posterior to the orbit, right? And this is where you have passage of cranial nerves 2, cranial nerve 4, 5, 1, 6, and you've got passage equally of the internal carotid artery, the ophthalmic artery. So you've got drainage into the intercavernous sinuses coming from the hypophysis. The functions of the hypothalamus. We start with hormones, endocrine. So the hypothalamus has been called by some people as has been said to be the brain of the endocrine system, and rightfully so. One thing I like to do in terms of remembering, well, obviously we know that we already said it, the anterior pituitary has an adenohypophysis, which is glandular. And if we're talking about what's being secreted here, the way I remember it is flat peak, FSH, LH, ACTH, TSH, prolactin. Now this I, you just remember as prolactin, the growth hormone, but this is not complete. You still have MSH, and you equally have, so this is, growth hormone, LS, this is prolactin. We don't have LH, FSH, TSH, and ACTH. And now the hormones are going to create stimulation or inhibition, produce stimulation or inhibition of these hormones come all the way from the hypothalamus. So if you know these hormones, then obviously you know the releasing factors or the inhibitory factors. For prolactin, we just need to remember that prolactin has prolactin inhibiting factors, and which the greatest example is dopamine. The other ones, you just get RH for the releasing hormones and IH for the inhibiting hormones. And another name for the growth hormone inhibiting hormone is somatostatin. Since we're talking about endocrinology, then it's interesting to understand how does the hypothalamus do this. We always speak about the loops, feedback loops, which can be positive feedback loops or negative feedback loops. If you're talking about the first two, FSH and LH, for the secretion of LH or FSH to be done by the pituitary hormone, by the pituitary gland, sorry, the hypothalamus has to secrete a sex hormone, which is a sex stimulating hormone. Now, this sex stimulating hormone is the same for both FSH and LH. So the question would be, how does the pituitary know when to secrete FSH and LH? We know this is very important, be it in women and men, or men, because in women, for example, we've got a cyclic menstrual cycle. So what happens actually is you've got pulsatile secretion of this sex stimulating hormone. And this sex stimulating hormone can be secreted either every 60 minutes or every 90 minutes. And depending on whether it's 60 or 90, you've got production of FSH or LH. And if it's secreted constantly, you have neither that's been produced. As a reminder, FSH follicle stimulating. So if you're in a woman, you're thinking about ovogenesis. If you're in a man, spermatogenesis. LH, think in terms of other hormones, so testosterone, estrogen, and its derivatives. So ACTH, corticotropin releasing hormone, will be acting on this, stimulating this production. TSH is the hormone that produces, leads to the production of T3 and T4. So the TRH hormone influences TSH. How do you get this modification? Well, because it's T3 and T4 are metabolic hormones, they should be able to have an idea of the energy stock, energy reserve in a person's body. And this is done via receptors to leptin. So leptin is this hormone that's produced by adipocytes. Depending on the levels of leptin, there's going to be a modified secretion of TRH and therefore TSH. So if the levels are low, this will be low. If the levels are high, this will be high. Very simple in that sense. Prolactin, in terms of lactation, and like we said before, its inhibiting factor is dopamine. So always think about this when you have a woman with problems in terms of amenorrhea and galactorrhea. Think about prolactin and dopamine. And the growth hormone, we said the inhibitor is somatostatin. Somatostatin doesn't only inhibit the growth hormone, it also has effects on vessels. Think about when you have spoliation, blood volume depletion. You use somatostatin if there's important hemorrhage. The growth hormone has effects all over the body to cause growth, obviously, but equally increase in the blood sugar level. So that was it for today. Thank you.
Thank you very much, Dylan. Excellent. let's turn it over to the panel for comments or questions. Any comments or questions from the panel, please? Come on, you guys, wake up.
My comment is just to say it was a marvelous presentation. I have no question. It was simply good. Perfect. Thank you very much, Dr. Ingrid.
Thanks, Zulu. Thanks.
Wish we had these presentations and when I went to medical school. So, any comments or questions?
Hey, John. Just I just have a comment. Hello?
Yes, go ahead. We can hear you.
Yes, I just wanted to say the presentation was fluid. It was really very much understandable. Not really very much to share. It's the basics of neurosurgery, neuroanatomy, and it was well explained, so it was great. Thanks. Thanks, Dr. Eric.
Thanks, Dr. Zulu.
Dr. Gabulo, you there?
Yes, I'm there. Thank you so much, Dr. Ilric. That was a good presentation. I think I don't have questions.
Okay, thank you for coming, Dr. Gabulo.
Welcome.
Okay, very good, Ulrich. That'll be a good reference video for someone that wants to brush up on the hypothalamus. So I thank you. I'll end this formally before we turn it over to Dr. Gabulo for the next presentation. So thanks everybody for coming. Okay, just stay here. We're just going to edit this and we'll seg into Dr. Gabulo's talk. Are you ready, Dr. Gabulo?
Yes.
Okay, let me introduce you first, okay? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Greetings. Good afternoon from Lisbon, Portugal. This is Dr. John Bennett, head of Neurosurgical TV. We have the pleasure of having a webcast done by Dr. Gabulo, Dio Gabulo. He's going to talk about hematomas of the hypothalamus. Before we turn it over to Dr. Gabulo, let's briefly introduce the panel. Hello, Ulrich. Ulrich, can you just introduce yourself, please? You're muted there.
No.
I'm sorry, I muted you. You unmuted me. I'm sorry about that. Okay, go ahead, Doctor. Go ahead, Ulrich.
Sorry, there's a. Oh, thanks,
Yeah,
John.
please introduce yourself.
Yeah, thank you. I'm Ulrich Sidney. I'm a research associate at the Program in Global Surgery at Harvard. Nice to meet you all.
Leader of this group. Hello, Igor. How are you doing?
Hello. My name is Nicharujo Igor. I'm originally of Cameroon. I'm year 1 in neurosurgery at Abidjan University.
Year 1, just starting the journey. Huh? Great. Okay, Dylan. Go ahead, Dylan. Please introduce yourself.
Hello, everyone. I'm Dylan Jofak, general practitioner from Cameroon. Nice to meet you all.
Very good. Thanks, Dylan. Zolo.
Hello, everyone. I am Zolo Ivan. I am a fifth year medical student from the University of Boye in Cameroon. I'm a member of the Association of Future African Neurosurgeons, and I'm happy to be here. Thank you.
Thanks for coming, Zolo. And first, Mohammed, are you there? Could you please introduce yourself if you are? Oh, I'll unmute you. Go ahead. Go ahead, Mohammed. Introduce yourself. I guess Mohammed may have stepped away. Okay, Dr. Gabulo, thank you very much, and it's all yours. Okay, Dr. Gabulo, you there?
Yes, I'm there.
Okay.
Okay. So let me share my screen. Okay, can you see my screen?
Yeah, perfect, perfect.
Yes.
Thank you. So thank you, to Ulrich, for that great presentation on circular anatomy of the hypothalamus. That was a thorough presentation. So I'm just going to give you a brief presentation, a few slides on hypothalamic hematomas. I'll just go on general things. I'm not going deep. So first, we lost one of the great presidents in Africa, Comrade Robert Mugabe. So we are crying, we are mourning Mugabe these days. Many presidents from Africa are here. So may he rest in peace. Okay, then we go back to our hematoma. Hematoma, that word is coming from Greek, hemasia, which means fold, or I'm sorry. Sorry, let me do this. The picture is obstructing my presentation, so I wanted to bring it up there. Okay, so hematoma is coming from Greek hemasia, which means fault or defect, and oma denoting a tumor or neoplasm. So it's a benign, non-cancerous tumor-like malformation, which is made up of an abnormal mixture of cells and tissues found in an area of the body where growth occurs. So other authors, they consider it as a developmental error, which can occur at a number of sites in the body. But in the literature, they describe several examples of hematomas, including the following. Usually, hematoma resembles a neoplasm, but in most cases, it does not show any tendency to evolve into one. So cases of neoplastic evolution have occurred with these lesions. Examples are chondrosarcomas arising in osteochondromas and the neurofibrosarcomas arising in patients with von Recklinghausen disease. So in addition, neoplasms can be associated with hematomas without directly arising from them. Examples are fibromas of the ovary and malignant ovarian tumors arising in patients with Page-Jeghers syndrome. So hematomas should be distinguished from choristomas because hematomas, they are composed with tissues that are normally present at that given site where they are arising. Whereas the choristoma, you get those malformations of tissue that are not normally found at that site. This is where they are talking about heterotopia. So when you're saying hematomas, choristomas, it's heterotopia. So you get malformations of tissues which are normally found at that site. They are coming from another place, like microscopically normal tissues derived from germ cells layers foreign to that body. So apart from this one, since we are talking about hematomas or talking choristomas, there is also what is called teratoma. So teratoma have been designated as benign tumors that contain representative component of all three germinal layers. So teratoma is also a tumor, but made up of several different types of tissues, such as hair, muscles, teeth, or bones, and they typically form in the ovary, testicle, tail bones, and also less commonly in other parts of the bodies, like in the brain. And when they come in the brain, they're always midline, especially in the pineal region, and also in around the cellular region. So the hematomas, they say, okay, hematomas, choristomas, and gangliocytomas, say these types of lesions arising in the hypothalamus are known as hypothalamic hematomas. And those arising in the cellar without attachment to the hypothalamus are called choristomas. So hypothalamic hematomas, they are also known as diencephalic hematomas or hematomas of the tuber cinereum. They are very rare. They are non-neoplastic congenital malformations arising from inferior hypothalamus or from the tuber cinereum. which is on the floor of the third ventricle between the infundibulum stalk and the mammillary bodies. So they also may occur as part of this syndrome. They are saying sporadic cases are there, but 5% of, many of them, they are sporadic, but 5% they may be associated with Pallister-Hall syndrome, which is a genetic autosomal dominant inherited defect, where this gene is participating in the normal shaping of many organs. So in this syndrome, you can also get hematomas. So in terms of clinical findings, there are many things. There are few things we can get with hematomas, but there are specific types of seizures you can get in this hypothalamic hematomas. The type of seizures, there is what is called gelastic seizures, which is a brief episode of unprovoked laughter. And they are the most characteristic type of, and are the earliest seizures manifestation. They present up to 92% of patients, but they are not pathognomonic because a neocortical origin has been described, also neocortical origin of gelastic seizures. They are resistant to medical management and can lead to cognitive behavioral deficit. So these are a few videos showing you, unfortunately, I don't know that side if you can see better the video. They are showing children with gelastic seizures. Okay, I think the volume is not there. Can you see the video?
Yes, yes, we can.
We can see.
Yeah, it's unprovoked laughter. You just see a baby who was sleeping or playing, starting to laugh. And usually it's rare to have loss of consciousness. So apart from gelastic seizures, we have also what is called epileptic encephalopathy, whereby it is coming after the gelastic seizures. So the first to arrive in terms of seizures is gelastic seizures. But when they are there, they are increasing in frequency. Then other types of seizures can also occur, like complex partial seizures, tonic-clonic seizures, secondarily generalized seizures, and this called drop attacks. The drop attacks are sudden falls without loss of consciousness that are not precipitated by specific stimulus. And usually they occur with abrupt onset and without warming sign. And they are followed by a rapid return to baseline. That's how they come to drop seizures. So the epileptic encephalopathy, this phase is associated with marked deterioration of cognitive and behavioral abilities. And they develop in 52% by a mean age of 7 years. So another sign apart from seizures with the hypothalamic hematomas, you can get precocious puberty, which is believed to be due to release of gonadotrophin release hormone found within hematomas cells. And the hematomas are the most common CNS tumors to cause precocious puberty, though there are also other causes, including other brain tumors, hydrocephalus, inflammation, and so on. So apart from seizures, apart from precocious puberty, you can also get developmental delay when you have hypothalamic hematomas. And that delay is primarily in patients with seizures disorder, and the severity correlates with duration of the seizure. The more you get the seizure, which are lasting, the more you get developmental delay. And 56% of patients have borderline intellectual function, mental retardation. And also you can get behavioral disturbances like aggressive behavior, like rage attack, that. Then other things you might get clinically, there might be variety of autonomic disturbances, like abnormalities of thermoregulation, since it is touching the hypothalamus. You can get behavioral disorders, like we mentioned before, somnolence and hyperphagia. Sometimes you can get hemiparesis or nystagmus, and also occasionally, since this occurs usually in children, you get also those children may present with cachexia. So radiologically, on plain X-ray of the skull base, usually it's unremarkable. Of course, you can see erosion of the dorsum celli, but in most cases, it's unremarkable. And on CT scan, you get, it will be isodense and not taking contrast. You see just a supracellular region, a supracellular mass, or interpeduncular cysternal mass, which is isodense and non-enhancing. On MRI, on T1 and T2, they are iso-intense, but others are saying on T2, they might be slightly hyper-intense. So you see that iso-intense mass, which is attached to the tuberous cinerarium or posteromedial to hypothalamus. Then the lesion may lie entirely within the substance of the thalamus and may therefore be easily missed if very small. Then according to pathology, there are two subtypes. There is the pedunculated and the intrathalamic. Pedunculated or parahypothalamic, it is a narrower base attached to the floor of the hypothalamus, and it is not arising within the hypothalamus. With this lesion, there is no distortion of the third ventricle, and generally it is associated with the precocious puberty more than seizures. But the intrathalamic or sessile, this one is within the hypothalamus, and you see that there is distortion of the third ventricle. So it is a broad attachment, like pedunculated means small base, sessile, broad base. And the intrathalamic, it's more often associated with seizures, and 66% have developmental delay and 50% have precocious puberty. So microscopic pathology, you will see clusters of disorganized small neurons surrounded by large pyramidal-like neurons in a astrocyte-rich neuropil, in contrast to the usual ganglion cells surrounded by oligodendrocytes found in the hypothalamus. So hematomas usually, like I mentioned again, resemble normal gray matter, but they contain neurons which are indistinguishable from normal hypothalamic neurons and may contain secretory granules. Those are the secretory granules which are producing luteinizing hormones, releasing factors. Also, those granules, they contain also beta endorphin, they contain corticotrophin, releasing factors, and oxytocin. But on immunohistochemistry, it is positive for hypothalamic hormones in the neurons of these lesions. So the natural history is usually unfavorable in the majority of patients because of behavioral symptoms. So interestingly, reversal of these behavioral symptoms after radiosurgery seems to begin even before complete cessation of the seizures. Then in terms of treatment, precocious puberty usually respond well to GnRH analogs. And indications for surgery, we go for surgery only when there is a precocious puberty that fails to respond to medical therapy. You also go for surgery when you have seizures that cannot be adequately controlled medically, or post-seizure control is related to completeness of resection. And the third indication is neurologic deficit from mass effect of the tumor. Once you get a neurological deficit attributable to the lesion, you have to go surgically. And options for surgery, it's according to the types of the hematoma. When you have the pedunculated one, you can go through subtemporal, subfrontal, or pterional approach, or orbitozygomatic approach, which is the most commonly recommended. And here the risk is cranial neuropathy, because remember, before you reach there, you have to cross many cranial nerves on your way. So if it's sessile or intrathalamic, usually they prefer to do a transcallosal anterior interphoneal approach. And the risk here is memory impairment because you might injure the phonies. And also there is another approach, neuroendoscopic approach, which is considered when the hematoma is less than 1.5 centimeter of diameter, and the risk is 20% incidence of thalamic cerebrovascular injury. So stereostatic radiosurgery, they're saying in small series, 3 outcomes showed improvement similar to surgical resection with less neurological and endocrinologic morbidity. This is why other authors are saying it is not important to do it. It's better to go for surgery than this one because almost the same result. But Ramamurthy is saying it's even not indicated. But those who are accepting stereostatic radiosurgery are saying you have to go there when especially the tumor is very small, sessile lesions. And also when you're going, after doing subtotal resection, you go for surgery, you do subtotal resection, then the remaining you do stereostatic radiosurgery. And also when patient is refusing surgery or the patient is not candidate to surgery. And surgery is indicated in most symptomatic patients. Like I was saying, according to Ramamurthy, they're saying radiotherapy is ineffective in treatment of these lesions. So surgical treatment is useful to confirm the diagnosis. That's the main thing. And also to regress or abolish precocious sexual features and skeletal growth. They are saying if you go and remove even a part of the tumor, you might improve, you might sort out the problem of precocious puberty. But there are also some drugs such as medroxyprogesterone acetate or cyproterone acetate, which have been used to inhibit gonadotropin production in patients with precocious puberty. So apart from surgical treatment, you can also use drugs. But if they fail, then you go again for surgery. Thank you for being there. These are my references. And once more, RIP to Mugabe. Thank you.
Thank you very much, Dr. Cabello. Sorry to hear about the passing of the president. Excellent presentation. Thanks a lot for taking the time on probably one of your days off. I'd like to open it up for comments or questions from the panel.
Thank you, Dr. Cabello. Thank you so much. That was very interesting and a very good compliment to what we just had. Thanks.
You're welcome.
Any other comments or questions? Igor, Mohammed, Dylan, Zolo? Come on, guys, wake up. There you go, Zolo. Zolo is awake.
Yeah, I'm always awake. Okay, thank you very much, Dr. Kabilo, for the presentation. Thank you very much for the presentation. It was really nice and quite comprehensive. So thank you very much for the presentation. Thank you. I have no question.
Thanks, Zolo. Thanks for coming. Okay, unless Igor or Mohammed has something to say. Dylan, any comments or questions?
Hey.
Go ahead, Dylan.
Hello.
Yes, go ahead, Dylan.
Yeah, thanks, Dr. Kabulo, for the presentation. It was really good. I wanted to know, is it possible to make any correlation between the type of hypothalamic tumor and the clinical presentation of the patient? So, like, for example, is there something, a typical correlation between the nature of the tumor and the clinical presentation of the patient?
Clinically, it's always difficult. Clinically, it's always difficult to differentiate those things, because even the gelastic seizure, which are described in hypothalamic amatomas, they are saying they are not pathognomonic. So clinically, it's very difficult, because anything, even something which is around the hypothalamus, just by compression can give you symptoms like you have something in the hypothalamus. I think you have to differentiate those ones from investigations, radiology, or after a biopsy. Clinically, it's difficult.
Okay. Thanks, Dr. Kabulo.
Thank you.
You're welcome.
Okay, Dr. Will, I'd like to thank you again, and thanks all the panelists. And before we go, Ulrich, you want to make an announcement about the next series, Ulrich?
Yeah, thanks, John. Let me quickly pull the schedule for the next one so that we can all, and I'll share the screen. Okay. So this will be our next lecture series where we chose neurosurgical emergencies. Now there's a few presenters, as you can see here. If you feel like you want to take any of the presentations, please get in touch, and we can always change this because a few of the presenters have quite a number of presentations. So from next Saturday, we're going to start with clinical evaluation of comatose patients, and that'll be me. And this is the rest of the presentation. So next week, 6 p.m. Central African time, that's 5 p.m. GMT. I hope all of you will be there. And obviously, thank you, John, for everything.
Okay, well, you know, the series is just...
I have a comment.
Go ahead.
It's okay. No, I was just saying, according to this, this is a nice one. So, Ulrich, for me, I'll be just doing like usual. The day I feel like I'm free, I can add a small topic from that presentation. The day I'm free, I can tell you 2-3 days before that, I will add a small slide, like few slides after that presentation.
Okay,
so,
that would be perfect. Thank you.
It's difficult for me to say, you know, I'm in the difficult period. In 2 months' time, I'm writing my final exam in November. So
you'll be okay. We know you'll be okay.
Yes, it's difficult to say put me this day, but I can still come and improvise myself.
Okay.
For your indulgence before.
Okay, thanks, Dr. Kabulo.
You're welcome.
Yeah, I'd like to say that this. Go ahead.
Yes, and the courage for his exam, we know he's going to ace it.
Thank you so much.
Okay, I'd just like to say that the series that we just completed on neuroanatomy will be available on a playlist so that you can watch all the videos, you know, one by one, as will the neurosurgical emergencies be put on a playlist that you can even watch from your smartphone. So thanks everybody for coming, and thanks Dr. Kabulo and panelists.
John.
Okay.
Thank you.
Thank you for everything.
Okay, very good. Thanks, Ulrich. I got lots of time to get to the wedding. I wonder why my camera's not showing up. Well, that's strange. But anyways.
So why are you in Portugal now?
Yeah, I will. We'll have a good time.
Why are you? Which city are you in Portugal?
I'm in Lisbon, a nice part of Lisbon on the ocean called Cascais. Cascais. Beautiful place.
You mean you are in Lisbon?
Yeah, I'm in Portugal now. Lisbon.
Oh,
Lisboa.
That's great. I remember I just spent few hours in Lisbon, but most of the days I was in Porto.
Yeah, right. Well, I'm televising a conference in neurointerventional neurosurgery. Yeah, on the 25th, Dr. Kabulo, will be online. The whole conference will be online. So you know, I don't know if you have an interest in neurointerventional, but they have a really good lineup, and it should be enjoyable.
Sure.
We're televising a conference from Ecuador on Parkinsonism the same time, but the times are different. In Ecuador, it's the day and it's the night, so it switches. Well, but I'm going to be on call, looks like, that week. I'm going to be on video call. But it's not bad just once in a while. I couldn't do it very often, but so thanks, guys. Got to run. Thank you very much for everything.
Thanks, John. Thanks.
Okay.